Hello. Thanks so much for viewing my poster and listening to this presentation. My name is Prabnur Chadwal, and I'm a fourth-year undergraduate student studying health sciences at Western University. Today, I will be discussing my research on misinformation and evidence-based communication during the COVID-19 pandemic. This research was facilitated by Dr. Shannon Siebold at the Lab for Knowledge Translation and Health at Western University. If you think back to March 2020, when COVID pandemic had just began, we were being flown in with tons of information and it was hard to judge which is right or wrong. And this is when the public health authorities started to talk about the spread of misinformation. So what is health misinformation? Health misinformation is any health-related claim that has been proven false or assumes a lack of scientific evidence. The effects of misinformation are extremely prevalent during the COVID-19 pandemic. Because in today's day and age, social media has been a huge driver for the spread of misinformation, which has led the World Health Organization to label the spread of false information as a massive infodemic. One of the big concerns with spread of misinformation is that it influences public behavior with the potential to elicit negative outcomes. This was seen when falsehoods spread through the SARS epidemic in 2003, Ebola outbreak in 2014, Zika virus public health crisis in 2015, and HIV/AIDS in South Africa, all resulting in public fear, discrimination, and stigmatization. During these epidemics, there was a lack of top-down flow of information, meaning there was a restriction of lack of information going to the public, which led them to constructing their own narratives, thereby spreading myths and conspiracy theories. My main purpose of this scoping review was to explore the sources and types of misinformation during the current COVID-19 pandemic and to understand how the social media policies/responses are aimed to limit the spread of misinformation, as well to provide recommendations for promoting public health literacy. The objectives of the study are to summarize the effects of social media during a public health emergency and describe current and newly implemented policies related to misinformation and public health. The methodology for this project was guided by the 5 stages protocol outlined by Arksey and O'Malley, which is generally used for scoping reviews as best practice and steps to follow. The primary concepts of interest in the scoping review were misinformation, social media, and epidemic. The main concepts were then used to generate keywords: misinformation and social media and variations of COVID-19 pandemic, SARS, Ebola, Zika, HIV/AIDS. A robust systematic search was implemented in automated database PubMed and Google Scholar for Gray Literature. We located opinion pieces and articles in the time frame between June 2010 to June 2020. All articles published in English were also part of inclusion criteria. Any articles addressing disinformation or fake news did not meet required definition for misinformation and were therefore excluded. Articles were independently assessed by 2 reviewers in 2 stages, and disagreements were resolved through discussion, consensus, or third opinion. First, titles and abstracts were identified in electronic database Covidence, were reviewed for eligibility using the inclusion criteria. Second, we acquired the full text of selected articles from Phase 1, further disposing those out of scope, and remaining 20 were included in the study. Next, data analytic process consisted of data mapping of bibliographic articles by author, year, focus of study, and main findings. The results were categorized into 4 different themes: sources and spread of COVID-19 misinformation, types of myths, rumors, and falsehoods, responding to online misinformation, and social media and related policies. Sources and spread of COVID-19 misinformation. So over half of collected misinformation is factual information, twisted, reworked, or recontextualized. 38% of the misinformation content from our sample was completely fabricated. 20% of the claims come from prominent public figures, and the majority of misinformation on social media is transpired from ordinary people. Types of myths, rumor, and falsehoods. There are all sorts of misinformation around the internet. Excuse me. Including magic cures, secret medicine, and government intentions, etc. These are some examples that have come up in the literature multiple times, but these are not limited to Bill Gates was responsible for spreading the virus, plagued social media forums, and that COVID-19 virus is a byproduct of 5G wireless technologies. This information has been spread in common languages spoken around the world, including Hindi, Urdu, Farsi, and Hebrew, reaching the mass population. Therefore, finding ways to respond and police this information is very important. This brings us to our next category, responding to online misinformation. Although fact-checking is a popular method used to counter misinformation, the benefits are limited, as it may not keep up with the fast pace of false information produced in times of crises. For this reason, researchers highlight the importance of cross-collaboration with different professionals. For example, psychiatrists could provide their perspective on how to address panic as a result of anxiety and apprehension to new information, and pharmacists could guide how to adopt a leading role in communicating up-to-date information. There is also potential for using real-time information systems to analyze geographical data in order to create response tactics. Social media and related policies. Social media websites like Facebook, Twitter, YouTube, and Instagram have initiated the process of removing unauthorized information through various initiatives. What is most common between all four platforms is the display of warning labels and education resources directed to viewers and their partnerships with fact-checking organizations for taking down any content that contradicts medical advice. The main point of discussion is we need to better understand how misinformation is processed on an individual level, how people obtain the information, evaluate it, and accept a claim before internalizing it. Studies are being done in this direction using real-time data collecting techniques and physiological measurements. For example, functional magnetic resonance imaging, eye tracking, and cognitive interviews are used to assess the rate at which people accept a claim before internalizing it. The second point of discussion is effective messaging to counter misinformation is more successful when people are encouraged to investigate and criticize their own information sources in an effort to better understand how this information is created or curated. Lastly, receptivity to health information can vary greatly depending on the source of the messaging and the recipient's social network, level of trust, and this includes developing their ability to discern trustworthy versus untrustworthy information and social media use patterns. To conclude what I've discussed, there are concerns about individuals being able to interpret and internalize healthcare information. Therefore, having health literacy is of utmost importance through better health communication guidelines and adopting an interdisciplinary approach. From our research, we see that online forums and social media platforms have been working collaboratively with government organizations, local health agencies, and independent fact-checkers to mitigate the amount of false information. The main recommendation from our research is directed towards healthcare workers and prominent social media figures. They should use this opportunity and use their influence to echo government recommendations and evidence-based information to a potentially more skeptical audience. Thank you for listening, and I would love to answer any questions you may have. You can reach me via email, which can be found at the bottom right of my poster.